for the opportunity to participate in this interesting case discussions. It's our first time presenting here, so I just want to take a few moments and to introduce our group here at OHSU. Our campus is pretty unique. It's in a beautiful location nestled in the mountains with a great view of the city and Mount Hood. The main hospital is here. This is the main hospital. On the same site, we also have the Children's Hospital. This is the VA over here, and this is Shrine over here. So it's a kind of a microcosm of the US healthcare system up on the top of this hill. We are a level 1 trauma center and the only academic center in Oregon. We also have Hillsborough and Adventist medical centers, which are community sites on the west and the east end of the city. The main hospital campus has 576 beds with greater than 1 million annual patient visits. We have a new patient tower coming under construction, which will add another 150 beds. And we're also moving forward with merging with another hospital system in the city, Legacy Health. So when that goes through, we will become the largest hospital system in the state and the largest employer with over 30,000 employees. The OHSU Spine Center is a combined ortho and neuro service. We have 4 orthopedic surgeons and 4 neurosurgeons. On the ortho side, we have myself, Dr. Phillip, Dr. Kark, and Dr. Yu. Dr. Yu did retire from operating last year, but he's still seeing patients in the clinic and helping with non-operative care and very active in research. These are our neurosurgery partners, Dr. Arena, Dr. Ryu, and Dr. James and Christina Wright, a husband and wife team. So we are a quaternary care center, referral center, and take care of the full spectrum of spinal pathologies, including degenerative, trauma, deformity, infection, and tumor. We have an active spine oncology program and a multidisciplinary sarcoma clinic. We also have a combined spine fellowship program with ortho and neuro fellows. So this is the top of the hill over here where the main hospital is, and there's additional buildings at the base of the hill on the waterfront. We have our clinics and our outpatient services here. There's actually a tram that runs between the two, which makes the commute kind of unique and very easy. The medical and the dental school is here. And we also have the Knight Cancer Institute, named for Phil Knight, the founder of Nike. We are actually successful with a fundraising campaign a few years ago, raising $1 billion with a B for cancer care and research with the support of Phil Knight. Okay, so intros aside, moving to my talk, I'm joined by our ortho fellow, Dr. David Lee, as well as one of my neurosurgery partners, Dr. Andrew Ryu, who will be each presenting cases. So I'll be discussing principles of en bloc resection for spinal tumors. The objectives are to review the indications for en bloc resection, understand the impact of resection margins on local control and survival, and discuss surgical strategies for en bloc resection. So en bloc resection refers to the removal of tumor in one piece, leaving a cuff of normal tissue around the tumor. So the goal is to remove the tumor like the orange here on the left, peel intact and not in piecemeal fashion like on the right. So why do we do an en bloc resection? It may provide benefit for local control and survival. However, it is a more aggressive surgery with higher complication rate. It typically involves a sacrifice of adjacent structures, including neural elements and critical vascular structures, and there can be morbidity and deficits resulting from resection of these structures. Boryani published this review of their experience with en bloc resections over the last 25 years. They found an overall lower local recurrence rate with en bloc resection. However, the overall complication rate was 45%, higher or 53% in combined anterior and posterior surgeries, compared to 32% in posterior-only surgeries. Other predictors of complication were neoadjuvant chemotherapy and radiotherapy, tumor extending beyond the vertebra, and invasion of adjacent structures. They also found that patients who have already had open biopsy or incomplete resection before referral to the tertiary or quaternary spine center had increased rates of recurrence and mortality. So what is the impact on quality of life of en bloc resections? Well, it's actually surprisingly quite good. Patients who underwent en bloc resection had physical and mental component scores about equal to the mean US population about a year or more after surgery. And this is better than patients with chronic back pain. The EQ5D was lower than the general population, but it was comparable to patients with myocardial infarction or coronary artery disease, and better than patients with stroke. So who gets an en bloc resection? We must consider patient factors, oncological factors, and surgical factors. Patient selection is very important. These surgeries often import significant physiological stress, so a thorough assessment of patients' comorbidities and their functional status is important to fully assess the risk of complication, morbidity, and mortality. Oncologic factors or tumor factors, such as histology and grade, also play an important role. Sensitivity to adjuvant chemo or radiation therapy factors in. Higher grade tumors may necessitate en bloc resection, and it's also important to fully stage the cancer and determine the full location and extent of the tumor. Surgical factors include location within the spine, adjacent vascular and visceral and neurologic structures. Surgical planning often involves staged anterior, lateral, and posterior approaches. Of paramount importance is patient counseling. It will be important to discuss the diagnosis, surgical plan, and potential functional deficits related to the surgical plan and expected prognosis. The feasibility of the reconstruction must be weighed against the likelihood and benefits of oncologic control or cure achievable with en bloc resection. The patient's goals must be clearly elicited, and treatment plans must be in line with these goals. And so also discussion of these cases at a multidisciplinary tumor board has been shown to improve outcomes, and the importance of having such a conference cannot be overstated. There should be representation from medical and radiation oncology, pathology, surgical specialties who might be involved in the surgery, as well as rehabilitation services. So tumors can be classified according to the Enniken's classification system. There's a classification for benign and malignant tumors. Benign tumors are described as latent, active, or aggressive. En bloc resections are considered for benign aggressive lesions such as giant cell, ABC, or chondroblastoma. Malignant tumors can be described using the Roman numeral system with Enniking, stages 1 to 3, depending on the histologic grade of the tumor, and then the further classification of A or B, depending on whether the tumor stays within the vertebral body, intracompartmental, or extends beyond the vertebral body. So malignant tumors such as chordoma, chondrosarcoma, osteosarcoma, and Ewing sarcoma can be considered for en bloc resection. And what about metastatic disease? One can consider en bloc resection for solitary metastasis and some cases of oligometastatic disease. It might be beneficial for radio-resistant tumors such as renal cell, hepatocellular, or non-small cell, and melanoma. And secretory cancers may also benefit, cancers such as pheochromocytoma or carcinoid. This is an early description of en bloc spondylectomies described by Tomita and others. It describes using these wire saws or jiggly saws to cut through the pedicles. It is quite an interesting read, so I encourage you, if you have the chance to look through this. But they also use the jiggly saw. They dissect bluntly anteriorly with their fingers, and then use the jiggly saw to cut through the vertebral bodies and disc spaces. So they split the vertebral body at the pedicles, remove the posterior portion, and then remove the anterior vertebral body. Tomita describes 7 different classifications for spinal lesions and recommended that these types 2 to 5 be removed with en bloc spondylectomy. These type 7s with multiple sites of disease are not candidates for en bloc resection. Building on the Tomita classification, the Weinstein-Boriani-Biagini system was developed to standardize planning of en bloc resections. It divides the vertebra into a clock face to describe the circumferential zones which are involved by tumor. It also describes the layers involved with the extraosseous soft tissues, most externally radially, moving inwards towards the spinal canal. They did describe 10 different surgical strategies for various situations. I won't go through all of them, but I'll show just a few just to show you how this classification system works. So in this example, the tumor involves clock faces 5 through 8, so it's primarily anterior, and the surgical strategy there is a vertebrectomy. In this example, the tumor is primarily unilateral, involving clock faces from 1 through 5, and this would be amenable to a sagittal resection. And in this example, it primarily involves the posterior arch. from 11 to 2 o'clock, and that would be amenable to a posterior arch resection. If a combined anterior-posterior approach is needed, often the opposite side of the tumor is approached first to open the neural ring. Then the second approach is done from the same side to deliver the tumor and reconstruct the defect. So we've also found it really helpful to 3D print a model of the tumor. So you can see the tumor here, an example of the tumor here in green, and you can help, it helps to visualize the anatomic relationships to critical structures. We've also used it to plan our cuts in some cases, to actually have sort of like a rehearsal and a dry run through our resection to make sure we are able to deliver the tumor in one piece. So why do we care about margins? The healthy tissue is the margin, and leaving a tumor margin prevents spillage and contamination of the cancer tissue in the surgical field. And there actually is not consensus on what constitutes a good margin. How thick or how wide does it have to be? From the trunk and extremity literatures, they would suggest 1 to 4 centimeter margin. Some data encourages a radical excision of the entire involved compartment, which is often not practical in the spine. The quality of the margin is also important, as tissues such as fascial tissue, periosteum, and dura provide better barriers against tissue and tissue invasion. So a 4 centimeter margin may not be necessary if it involves fascia. An appropriate margin also depends on the tumor grade, so with less of a margin needed for low-grade tumors. There are a few different ways of describing margin, so I'll review a couple of those ways now. The AGCCR system is commonly used, and it describes a R0 resection as negative, grossly and microscopically negative resection. R1 means microscopically positive, and R2 means grossly positive. The MSTS describes a radical resection as all normal tissue in the involved anatomic compartment excised en bloc. A wide resection as histologically non-reactive normal tissue at the margin, a marginal resection as pseudocapsule present at the margin, and intralesional resection as tumor present as the margin. So in anything, appropriate resection refers to tumor resection with appropriate margins. And then there's also just measuring, just a straight measurement of the distance from the edge of the tumor to the resection margin. So looking at, this group studied, they looked at the local cumulative incidence of local recurrence using these different classification systems for margins. So looking first at the R classification, as expected, the R0 negative margin resection had the lowest recurrence rate, shown here in the green and the dashed green. The dashed green just means with postoperative radiotherapy. So however, note that with R1 or microscopically positive margins with radiotherapy, the local recurrence rate approaches that of R0. And so according to the MSTS classification, the wide or radical margin has the best outcomes with the lowest recurrence. The intralesional or the marginal resections had the worst outcomes or highest recurrence. But if you had an intralesional or marginal resection and the patient received post-op radiotherapy, that was able to improve the recurrence rate to about 20% at 3 years. And then if you just look at the straight measurement of the thickness of the margin, down at the bottom here is, in green, is the greater than 3 millimeter margin, again, with or without radiotherapy. Those have the best outcomes. But also note that if you are able to get a 1 to 3 millimeter margin with radiotherapy, that approaches the wide resection, or the greater than 3 millimeter margin. So there's no definite consensus on the appropriate margins, but the evidence would suggest that the best outcomes are negative margins with greater than 3 millimeter cuff of tissue with or without radiotherapy, or between 1 to 3 millimeters with radiotherapy. And those can get the recurrence rate down to less than 5% over 3 years. But even a positive margin with post-op radiation can lower recurrence rate down to about 20% over 3 years. And just keep in mind, due to tissue shrinkage from the histologic processing and the formalin, a 2 to 3 millimeter margin seen by the pathologist probably represents more of like a 1 centimeter margin in vivo in the surgical field. And often we have no choice but to leave a positive margin against critical structures like the dura or the aortic wall, as resectomies would greatly increase the morbidity of the surgery. This is what is referred to a planned positive margin. Planned positive margins along critical structures is acceptable, in particular in patients who receive preoperative radiotherapy. Unplanned positive margins due to surgical error or extension of the tumor beyond what is seen on the imaging, pre-op imaging, has the highest risk of local recurrence. The Toronto group here called this a whoops procedure. So patients with low-grade sarcoma, as sort of like their baseline, found out they had a local recurrence of 4.2%. A planned positive margin had a local recurrence of 3.6%. A positive margin, so if the surgery was done at an outside hospital with an unplanned excision and a positive margin, if that patient was then referred to a tertiary center and had a re-excision, their local recurrence rate is 32%, and then unplanned positive margin has a recurrence rate of 38%. So in summary, the treatment of primary spinal malignancies is associated with high morbidity and mortality. Patient selection, surgical feasibility, and tumor characteristics all should be considered. En-bloc resection can offer better local control and survival, but should be weighed against potential complications and morbidity. Planned positive margins along critical structures may have a low recurrence rate, and careful multidisciplinary planning and discussion with patients regarding their expectations and goals of care is paramount. And that's it. Any questions right now before we move on to cases?
Cliff, this is very nice. I have one actually. So in advanced modern tumor monitoring, where are PET scans relative to TC99? I'm from the TC99 era. Is that just completely gone now? Or does that mean something to you as an orthopedic oncologist? Are we all into PET scans for everything all the time now?
I don't know what I don't know enough to know what the actual differences are. I have noticed that PET scans are used more often than the previous bone scans. But I actually honestly won't be able to tell you what the specific differences are between those two modalities.
All right, a great summary, by the way. I'll ask one question before we go on to the cases, and that is, what is the role of radiosurgery in trying to have a better chance of getting a margin on some of these that are tough to get Enbloc margins to? Do you work with the with the folks that do the radiosurgery and try to supplement your surgery?
I mean, so post-op radiotherapy with a margin definitely improves outcomes and can decrease the local recurrence rate. Are you sort of referring to like separation surgery, or?
Yeah, I used the wrong term, but kind of doing the kind of the team approach and trying to create a margin where there might not be a really good margin.
I guess it depends. If you're doing separation surgery, that sort of implies that you're digging into the tissue around the epidural space to make more space around the thecal sac. But that seems to me that you'd be entering the tissue, which makes that not an en-bloc resection at the time.
Okay.
I think that's more for like metastatic disease, metastatic epidural radio separation surgery is more in the application of metastatic disease and epidural compression. I'm not sure how much it's used in terms of these primary malignancies.
Okay.
But I think that one thing that we do participate a lot is the consideration for neoadjuvant therapy. So putting neoadjuvant chemoradiation to potentially shrink the tumor. So there are times where if there are critical structures that we aren't able to achieve potentially a R0 or R1 resection, neoadjuvant therapy, if the tumor biology allows response, you potentially can have a a surgical, non-surgical candidate for an en-bloc resection turn into a surgical candidate. So that has happened.
Yeah, there is definitely a role for, as I agree completely with Dr. Ryu, with neoadjuvant therapy and actually making planning for an en-bloc resection, making it more feasible.
Got it. Thank you.
Okay, so I'm going to hand it over to Dr. Lee, who's our fellow, who's going to start with the first case.
All right. Everyone see my screen?
Yes.
Perfect. All right. I'm David Lee. Thanks for having me. I'm the current OHSU Spine Fellow. I also did my orthopedic oncology fellowship at University of Washington, and I'll be presenting case 1. So TD is a 54-year-old female. She had a 1-year history of atraumatic low back and left leg pain. It was initially thought that she had a muscle strain, so she went to her PCP and got evaluated and got recommended conservative management. She tried over-the-counter medications, PT, and went to the chiropractor without any improvement. She had conservative treatment for approximately 7 months without any improvement. Past medical history of morbid obesity. She had a BMI of 42. Past surgical history, none, and she didn't really have much of a social history either. Physical exam upon presentation, she had some pain with range of motion of the right and left hip, but otherwise she was neurovascularly neuro intact. She had full strength of lower extremities, and she had full sensation in lower extremities as well. So pretty benign physical exam. So upon presentation of her PCP, after 7 months of failed conservative management, she got radiographs with her PCP. Standing upright x-rays didn't really show much. And, usually whenever you're concerned about malignancy, you sometimes see a lytic process, or sometimes whenever there's a soft tissue component, you can see a soft tissue shadow, but you don't really see much of that. Little mild degenerative changes on the AP and the lateral, but not much you can see. Flex X doesn't really show any instability. Still don't really see much of anything going on there. And radiologist noted the same thing: mild lumbar scoliosis and spondylosis. And so after negative x-rays, they proceeded to get an MRI with and without contrast to further evaluate, which kind of showed us this. So at the L2-3 level, you see this enhancing mass in the left psoas. As you scroll down the MRI, you can kind of see that it involves a TP more, and involves a little bit more of the paraspinal musculature posteriorly. Down towards the L4, you can kind of see it involving more of the TPs, more of the paraspinal musculature as well. And if you look at the T1 sequences on these, the kind of good anatomical capture, you kind of see the nerve roots at L2 and L3 kind of diving into the mass. You can see the paraspinal musculature on the left side, and you can see kind of nerve roots diving into the mass for L2, L3. We weren't sure if L1 was involved or not in the axial. We didn't really see much on there, but whenever you look at the sagittal there, you can kind of see the nerve kind of coursing over the mass on the sagittal view. And so the L1 nerve root might or might not be diving into the mass, so we suspect that was involved as well. And so after seeing these images, her PCP referred her to us. And so the first thing we did is we want to know what it was. And so we did a CT-guided biopsy, which showed that it was a sarcoma. More specifically, it was a malignant peripheral nerve sheath tumor, so MPNST. And so after seeing this, getting the results of the biopsy, we started our sarcoma workup and also our treatment for her, which involves staging studies and also neoadjuvant radiation with subsequent surgical resection. So staging studies, her CT chest was negative for any metastatic disease. She saw the radiation oncologist, which kind of got more of a hyperfractionated radiation course of 42 gray and 15 fractions. And then usually after radiation, 46 weeks afterwards, so we can let the soft tissue heal to decrease any wound complications, that's when we would proceed to surgical resection. And so whenever we see a sarcoma, we think about staging, like Dr. Lin said, we think about the Anakin staging system. And so she was considered a stage 2B. She was high grade on histology. It was extracompartmental, so it was outside of even the spanning multiple compartments. And on staging studies, she didn't have any metastasis. So stage 2B, which is the most common stage that we find a lot of these sarcoma patients when they present to us. And anatomically, whenever we look at how we plan our surgical resection, she was involved in zones 3, 4, and 5. So the TPs, the pedicles, and some of the cuts. You can also see a little bit of involvement in the vertebral body as well. And it was interosseous but superficial. And so during the 4 to 6 weeks between radiation and surgical resection, to let the soft tissue heal, we also think about our goals of treatment and what we're going to want to do. And so we want to obtain negative margins on this tumor. And just like Dr. Lin said, we want the debate for how much of a margin we get is up to debate, but we think about 2 centimeter margins what we really want. But we want to balance that with the morbidity of what we would ensue on the patient. And so close to the spine, we want to balance what morbidity that she's going to undergo. We want to identify and resect appropriate nerve roots. So we know L2 and 3 are involved. And so we will be resecting those. And we suspect L1 would be involved as well on the left side. We want to identify your vascular structures. And so the segmental arteries of L2, L3 we believe would be involved. So we want to plan that during our surgical section to minimize any bleeding during that time. And so what our plan was, we're going to do a 2-stage procedure. Stage 1 would be a standard midline approach where we approach it posteriorly to do our resection. So we do L1 through 5 on the left side, posterior spinal instrument fusion. We would do our partial corpectomy from L2 to 4, and we would identify our nerve roots L2 and 3 and resect those nerve roots. And then stage 2, which we did on the same day, we would have general surgery come in and do a retroperitoneal approach, so we can approach it more anterior, and so we can ligate the segmental arteries as we identify them from 2 to 3, and also do our Enbloc excision. So we would plan our resections caudally and cranially. So we'd resect the psoas as a cuff of normal tissue at specific levels. So cranially, we thought we would cut it at L1 and 2, and caudally we would cut it at L5. And so this is what we kind of had posted up in the monitor up in front of the room. I think it's kind of good to have to kind of remind ourselves what we're going to do, what our dangers are, what our margins are going to be, and what our goals are for surgery are, as we kind of look up and kind of know, like, okay, I'm getting close to my margin. I need to kind of go further, or, oh, this is what I'm planning to do, because there is a lot to it. And so I think it's great to have it kind of posted up in front and refer to it. And so we'll kind of go through it via this MRI slice and what we're going to do. And so looking at this MRI slice, we knew we were safe on the right side because the tumor is on the left side. So we exposed out to our TPs during our stage 1 from L1 to 5. On the left side is where our tumor was. So we exposed up to our facet joints here because that was the closest that we were comfortable getting close to the tumor there. And then once we were able to expose out from 1 to 5 to our facet joints, that's when we were starting taking our cuff of normal tissue from our soft tissue mass. So you can see a little bit of a normal rim of tissue of the paraspinal musculature outside of the soft tissue itself, and that would be our margin. Once we did that from the levels from L1 to 5, that's when we started placing our pedicle screws. And so we placed our navigated pedicle screws from L1 to 5 on the right side. That's where we're safe. And we put our pedicle screws at L1 and 5 because on the left side, because in between is where we're going to make our resection. And for our resection, once we placed our screws, we were able to proceed with our resection. So we did our laminectomy, which exposed our nerve roots. So we took nerve roots L2 and L3, and we resected those, which gave us exposure to our vertebral body, which we were able to do a navigated cut for our via our osteotome for the hemivertebrae cuts. And so if you look at kind of the AP X-rays on here, this kind of illustrates our cuts, kind of at the spinal laminar junction there. And so then we would place our rods for our over our screws, and then we would place our graft, and we were able to close up the patient and reposition the patient for stage 2, which general surgery helped us out in that. And we placed her in a right lateral decubus, so left side up, so we can do a retroperitoneal approach. We were able to identify our L1 nerve root from there, and then we saw the L1 nerve root actually dive into the mass, so we had to resect that. We also identified our segmental arteries, like I said before, to minimize bleeding. So L2, L3 was the one we were able to identify and ligate. And then we set our borders, essentially. We got a rim of normal tissue at the psoas, and we resect the psoas at the L1, L2 level cranially, and caudally we resected at L5. And I did forget to say that during our previous osteotomy posteriorly, we didn't do a full osteotomy. We kind of just left a little bit anteriorly so we can connect it when we went to our anterior aspect, which we did. So during our anterior exposure, we just connected our osteotomy anteriorly. And so we were just able to deliver the mass after that. This is kind of gross pictures of the mass itself. You can see this nerve right here. Sorry, that's in blue, doesn't show up much, but you can see the nerve coursing above the mass and kind of diving into it. This is a cross section of the mass itself. You can see the transverse process involved at that cross section. And all margins were negative, which is great. So these are our post-ops, our 4 weeks post-ops. Got a CT scan while she was in the hospital, kind of looking at our cuts. You see L2, we see a heavy vertebrae cuts, screws on the right side. Same thing in L3 here. So post-operatively, she did pretty well. She had an uncomplicated medical course. She used a knee mobilizer during ambulation. She was discharged to inpatient rehab on post-op day 18, mainly because of placement issues. She didn't have any medical issues going on while in the hospital. She was able to stand for transfers in the knee mobilizer. She had occasional buckling. She had buckling of the knee because she had weakness in her hip flexors, and she was unable to extend her knee. But she was progressing during physiotherapy. So what I learned from this case, I mean, a lot of what Dr. Lin said about counseling your patient, setting up for success, and like telling them what to expect after this large resection that you did. So basically letting the patient know the deficits that they will have post-operatively. I think they'll expect that post-operatively, and then I think this is what contributed to our patient's success in physiotherapy, where she kind of pushed herself through physiotherapy. So I think that's really important. Interdisciplinary care is vital for success. So we had our general surgeons, our radiation oncologist was helped us get a close margin, but negative margin. Our orthopedic oncologist and the spine team are all contributes to the success of the patient. I think it's important to kind of plan it all together to help the patient. And this is a difficult patient population to treat. You know, a lot of our elective patients, I think we can kind of optimize them in the nutrition manner, and also like speaking to them about smoking. But this patient population is tough because you have a time frame in which you have to intervene and surgically resect, and so you don't have that time to optimize the patient like you do in your elective patients. And tumor biology is important. You know, you have your carcinomas, you have hematologic malignancies, you have your sarcomas. All 3 are treated differently. I think, you know, a lot of it you can do with radiation, and others you can do with keratosis and intralesional treatment. But sarcomas, you have to do a marginal, especially with a localized sarcoma, you have to do a wide resection and have margin to them. So, and that's what we did. We did a Enbloc wide excision. Thank you.
That's a great case. I'm assuming, and I'm going to let Jens follow up because he knows more about this than I do. You consult with your interventional radiologist to make sure that their CT-guided needle biopsy is through the surgical site that you would do your Enbloc resection. I assume you do that because obviously the MRI appearance was very concerning. You knew it was going to be something bad.
Right. Yeah. During tumor board, we always kind of consult with our radiation oncologist and kind of tell them where to do their needle biopsy to kind of help our resection as well, kind of also including that biopsy tract into our resection.
And then again, I don't know that this would change your surgical plan, and I don't even know whether this is something that's on the radar screen anymore. But as you're getting further north in the lumbar spine, do you worry about, and is it a big concern anymore, the major radicular artery for the spinal cord on the left side between, it used to be, we thought it was between T10 and L1 or 2, the artery of Adamkiewicz with being a major segmental. Is that part of your workup or discussion with your vascular access surgeons?
Yeah, I think we would have them on hand, but I think we were trying to minimize our cut as much as possible distally in order to avoid that, knowing that that would be a concern. So, you know, like balancing the morbidity of resection versus what we have to do to get margins. I think we try to balance like going as distal as possible to get away from the vascular structures.
I thought that was a great case. Well done. And particularly the emphasis on functional limitations. So that exchange of radicality of excision and functional implications for the patient is really difficult to navigate. And patients frequently don't have a very good realistic understanding of what they're actually facing. So I thought this is really well emphasized and also done. Technical questions. So going on to what Scott said, number one, the role of preoperative embolization in Enbloc, is that nowadays almost a routine thing? Does that make your life easier? And number two, intraoperative navigation, especially as you cut off an anterolateral vertebral body. So does that help you as you're trying to do your cuts for the vertebra to have an exact orientation relative to your plans? So preoperative embolization as a routine measure for Enblocs, and number two, intraoperative navigation. Thank you.
I think preoperative embolization is has a mainstay for certain tumors that we consider. So, your renal cell carcinomas, your thyroid carcinomas, those are the big things that we consider because those are really bloody surgeries. We didn't really have much blood loss in this one. Even multiple myelomas, we sometimes considered preoperative embolization, but I think minimizing the amount of interventions this patient had was important, and we didn't think blood loss would be. I didn't think preoperative embolization would change the course of the bleeding for this patient, so that's why we didn't consider that. But it does play a role in certain tumors that we treat. In terms of navigation, I think that was important. I mean, I think navigation has been kind of the patient care standard that's coming up these days, and I think in the institution that we did this case at, I think that was kind of a standard of care that we had. Navigation, I think it's great that we kind of minimize our resection for the navigated osteotome and kind of like not just cut off a vertebrae at the majority of the vertebrae or a different amount of vertebrae at different levels. I think we were able to precisely cut a certain amount of vertebrae at each level that we plan. And so I think it's good to be able to be precise and have a precise cut at each level.
Thanks, David. I would also add, in terms of the pre-op embolization, certain of the benign aggressive tumors, such as giant cell or ABC, you might also consider pre-op embolization. But because you're taking, I mean, and I think that's one sort of issue when you're doing intralesional resections, because you're doing en-bloc resections and leaving the capsule intact, often there isn't actually that much, peritumoral bleeding. And then I will also say navigation has been a game changer, especially for those vertebral body cuts. Being more precise and taking out just the right amount of vertebral body. I know in this case there was no reconstruction of the anterior column because we were able to take out less than the lateral, only the lateral third of the vertebral body, and so being able to use the navigation to plan those cuts. And I'll show you in the next case. I'll talk about the next case. Other use of navigation, but yeah. Okay, so I'll start the second case here. Okay, similar but slightly different flavor. This is a 67-year-old female with high-grade pleomorphic sarcoma resection from her left buttock done in 2014, 10 years ago. So she since then has had a disease-free course, but then 6 months before presentation had a sudden onset of mid-back pain while lifting her granddaughter. The pain was radiating to the lateral abdomen. It's intermittent. She's still able to walk or run for several hours with some random jolts of pain and some pain caused by twisting, but she's not so severe that she needed to take any pain medication. She's an extremely active, healthy lady besides the previous sarcoma. She has a peristomal hernia from the previous sarcoma resection, and is otherwise healthy with BMI of 21. She has some osteoporosis. I haven't shown you any imaging yet, but the SIN score for this lesion is 5 points. So here are her X-rays. I'm not sure, may not present over the internet here, but it's got some atypical features from a regular osteoporotic compression fracture. You can see there's a bit of bridging bone anteriorly across the disc spaces. So that prompted an MRI, which showed this lesion involving T9 that kind of bridges across the disc spaces here into T8 and T10. This image here is with GAD and with contrast, and you can also see that kind of involves, it expands into the epidural space a little bit and starts to involve some of the pedicles. This is a PET scan, and it shows the lesion, in the spinal lesion here at T9, but also a small lesion on the rib, very kind of superficial here, I believe, on the 9th rib. And this is a CT scan showing the predominantly lytic lesion involving mainly the anterior vertebral body. So a biopsy was done of the T10 lesion, which showed pleomorphic sarcoma, and it was high grade with extracompartmental and distal metastases, but oligometastatic disease with the spine lesion and the rib lesion. So this classifies an NKing 3B. So what are her options? So I'll kind of stop here and open it up for discussion. Is this a patient who is a candidate for Enbloc resection, or given the metastatic disease, or should we pursue non-operative palliative treatments? And if it's operative, those who think want to do operative, what sort of technique would you use here? And the question being, does the oligometastatic disease with mass on the 9th rib have any impact on the decision making?
In the interest of time, do you want to proceed?
Yeah, I'll go ahead. So we did talk to her about Enbloc resection. So the pros, she's a healthy lady with a good functional status, and the surgery is feasible without a significant functional deficit. We might have to cut one of the, probably the T9 nerve, which patients tolerate generally quite well without significant functional deficit. The cons are that this is a high-grade tumor, will likely require an anterior posterior approach. The soft tissue mass is expanding beyond the vertebral body and abutting aorta, which is abutting the aorta, which is a poor prognostic factor, and also the fact that it's oligometastatic disease. So this is the Weinstein-Boryani Biagini diagram. Occupies the clock faces from 5 to 9, and it also extends into the epidural space. So the plan was for a Enbloc vertebrectomy and wide resection, or at least a marginal resection. So on day 1, we did the posterior approach. We instrumented from T4 to L2, skipping the 8, 9, 10, and then a laminectomy from T8 to T10. We resected the pedicles and the rib heads at T9, ligated T9 nerves. And then from posterior, kind of dissected extracapsularly, anteriorly around the vertebral bodies as much as we could reach, taking care to not disturb the tumor capsule. And then we used the navigated osteotome for the cephalad cut below the T8 pedicle and below the T10 pedicle. And then we placed rods and fibular strut grafts to span the osteotome site. So what we were able to do with osteotome is basically cut 2/3 of the way, not completely through. These are the cuts here. So above and below the lesion, as you can recall, it sort of spans across the disc spaces. So we wanted to make sure we cut above and below that to be able to get our margins. And then from posteriorly, we resected the pedicles and the rib heads to be able to detach it posteriorly. And then from day 2, we did an anterior approach with lateral decubitus. Thoracotomy was performed by thoracic surgery. They did some additional soft tissue dissection, particularly the peri-aortic dissection. And then we were actually able to, intra-op, we were actually able to see the cuts that we did from posterior. So we just placed the osteotome within those cuts and then completed those cuts across the vertebral body. And then we reconstructed and we able to remove the tumor en bloc, and then we reconstructed with a femoral shaft allograft. And these are the post-op images. So we did get negative margins. Closest was 1 millimeter. She did get post-op radiation to the spine. The rib lesion was eventually resected within a few weeks. That was also resected essentially en bloc with negative margins. She was started on denosumab post-op, and then did eventually return to playing tennis and golf. She had minimal pain, takes the occasional Tylenol. This was an MRI done, I think, maybe 2 years post-op, just for surveillance, showing no local recurrence. And I will put out, so we did use titanium instrumentation, and with the femoral shaft allograft and the titanium rods, there isn't too much metal artifact. There is more so artifact where we use the connectors and the dual-headed screws, but through the area of the resection here, you can see we actually have a pretty good view. And then 2 years post-op, again on surveillance, she got another PET scan, and unfortunately, she has additional lesions in the lung, in the liver, in the pancreas, and the femoral shaft, but no recurrence in the spine. So the question was it all worth it? I haven't actually had that PET scan was just a few weeks ago, so I actually haven't had a chance to talk to her about it. But I think she got 2 years of a good quality of life, doing what she wanted to do. I think the local recurrence rate was lowered. Did it extend her survival? I'm not sure. Would this progression of systemic disease happen regardless? But yeah. Any questions?
Well, certainly with the stability of her spine, you increase the quality of her life. Whether you increase the length of it, like you said, you don't know, but certainly quality, it was worth it.
For sure, yeah.
The question in terms of en bloc resection, this is beautifully done, by the way, must say, is costotransvasectomy and kind of the good old-fashioned kind of an en bloc resection with a turning out of the vertebral body. So I've actually done one about a year or two ago, the last time, and I still find that to be a very elegant single incision approach, which does allow a very clean margin resection usually. So I know there's a little prevertebral disease here, which makes this maybe a little bit more problematic, but together with the Ziegler saw the old Tomita turnout costotransvasectomy, how does that factor into your decision making?
I mean, I guess I was just more comfortable approaching this from anterior, and being able to get the section around the anterior to the vertebral body and the plane between the tumor and the aorta. I don't have I don't have the experience as Tomita describes with the wire saws. I mean, I guess you could still just use the navigated osteomes would be the same type of application of the tool. But I think definitely posterior only with a single incision is still an option.
I did a very nice job of that. The sorry, I have a rasp in my voice. I'll stop my questions. Go ahead.
Okay, so I'll turn it over to Dr. Ryu for our third case.
Thanks, Cliff. Oh gosh. Sorry, guys. Oh, I think I'm gonna have.
While still getting, oh yeah, here you are. Never mind.
Your microphone's muted, Dr. Rio.
Can you hear me now?
Yes, we can.
Perfect. Thanks, everybody. My name is Andrew. I'm one of the neurosurgeons at OHSU. And quickly go through this case with you. We have a 20-year-old young lady who presented to my clinic after 8 months of neck pain. She noted some worsening with flexion extension, but she's, aside from mild asthma and smoker, really not a significant amount of medical history or red flags. Denied ridiculous symptoms, denied any dexterity or gait instability concerning from myelopathy. She first started her course of her medical care through the chiropractor who got an X-ray. When I saw her, her exam really was not remarkable, except for some right-sided C3 dermatome numbness, but no myelopathy, neurologic motor intact, and no cranial nerve deficits. So, this is kind of where it started with her her medical care. And in this X-ray, we see that there's lucency in the upper cervical spine. Oh gosh. Sorry, guys. And you see that there is a kyphotic deformity with some lucency in the C3 lateral mass and facet. And that subsequently led to an MRI. This MRI sagittal with T1 with contrast, which show that there's a avidly enhancing lesion in the spine. And in the axial kind of key cut, you see this enhancement around the posterior element extending into the transverse foramen and somewhat into the vertebral body. Quite concerning. CT scan showed this lytic lesion largely in the spine, posterior elements, but also extending into the pedicle and a little bit into the ventral vertebral body.
She give like the typical neoplastic night pain kind of thing, or is it just non-specific pain?
Yeah, non-specific pain. Thank you for that. She didn't have anything. I think it was more like that. It was just persistent. It just kept going. But it wasn't a nighttime pain that I was taught to kind of look out for. This was after I saw her. This was presented within the spinal oncology program, but also there were, because of her age and the appearance of the imaging, it was quite concerning. So we forwarded to the the multidisciplinary sarcoma board. And also there was some discussion regarding the proton center about other therapies. But the first thing what we did was a CT guided biopsy, which showed that this was a chondrosarcoma. So based on this, and also the finding that you had a quite a large, almost a circumferential tumor, and involving the vertebral transverse foramen. The challenge was to find to determine, number one, if this is an Enbloc resection, feasible for Enbloc resection. But the recommendation from the sarcoma board for this patient who had a full workup, which was that this was an isolated lesion, there was no sign of metastasis, that an attempt for Enbloc resection was the best course for her. So that's what we planned for. And we talked about multiple times in this presentation about the WBB system. And it's a bit of a combination of things. I think with this case was quite challenging because we have to navigate through the cervical spinal cord, but also vertebral artery. And so the first thing we had to do is to determine whether the vertebral artery on the right side was something that we can sacrifice. So we got a traditional angiogram, and based on her full circle of Willis in the brain, and also her left vertebral artery being quite prominent, and backflow, we believe that this was something where the patient can tolerate the vertebral artery resection, ligation on the right side as part of the tumor resection. Another thing that we talked about here is the utility of a 3D printed. So now at OHSU, we regularly do patient-specific 3D printing, and for this, it allows us to do a run through, including the corpectomy cuts and tumor removal around critical structures like the vertebral artery and the spinal cord. So the first thing we did for her was a preoperative halo placement. It was a multi-stage procedure. The first stage, we did an anterior approach to the tumor resection or tumor dissection. So first, we worked with an ENT surgeon to get an anterior approach to the cervical spine. And we skeletonized the vertebral artery at C3 and 4 because that's the vertebral artery that we needed to protect as we planned for a sacrifice ligation of the right vertebral artery. We also did a right-sided anterior approach to the cervical spine. We skeletonized the vertebral artery at C2 and C4, not getting into the tumor. Right vertebral artery was ligated, and we dissected as much as possible around the lateral mass bilaterally because this was going to be a tumor that we're going to try to remove from the back. The right C3-4 nerve roots were ligated, and we did a cut above and below the C3 body, which was our part of our anterior disconnection. And we completed our anterior decompression, corpectomy of the right side of C3, which was the tumor-free side of the vertebral body. Temporary anterior cervical plate was placed, and we started the second stage on the next day. Started with the posterior approach to cervical spine, occiput to T1. Bilateral C2, C6, C7, T1 screws were placed. Occipital plate was placed. We removed the posterior elements of C4, free tumor. We then freed the tumor cranially and caudally around bilaterally. We ensured that the vertebral artery on the left side was freed. And then once the posterior disconnection was completed, we hinged the tumor around the spinal cord, and the final instrumentation was placed. To complete the instrumentation and fusion, we utilized a bilateral fibular strut graft. And this was the final tumor as it came out in one piece. This is the corridor that allowed us to remove the tumor around the spinal cord. So quite a small corridor, but we were luckily able to navigate that through. And this was the final cut. So you can, as a summary, the left-sided anterior cervical cut, the right-sided cut, dissection. This is the corridor that we created for ourselves with the left vertebral artery that we skeletonized and made sure that it was safe. The right vertebral artery, which was sacrificed for us to rotate the tumor around the spinal cord here, so counterclockwise to get it around the spinal cord and deliver it posteriorly. That was the end result with the spinal cord, ligated nerve roots, instrumentation. And the third stage was to use a tricortical autograft anteriorly and replace the plate anteriorly. So the main thing for this is, as it was previously noted, it's a complex surgical case that required multiple teams to make sure that the patient was safe. We had a patient who was neurologically intact, who we hope to get an Enbloc resection. So there was ensuring safety of the surgery, but also maximizing oncologic benefit for her. It involved neuroradiology, radiation oncology, pathology, orthopedic oncology, orthospine, and neurospine. And we know that at OHSU, we're big fans of the multidisciplinary team approach to sarcoma and complex oncology management. And on a monthly basis, we have the spinal oncology team that would discuss tumor cases, but also weekly sarcoma board. And the benefit of it is different specialty, different experts have different perspectives on how to keep the patient safe and on how to best manage patients. And in a paper that showed that multidisciplinary team approach does significantly and frequently alter cancer management up to 50% of the cases. And this is kind of my own experience also. Another thing that we've kind of started to incorporate within our sarcoma and tumor management is use of other instrumentation materials, so including carbon fiber. So this is a recent procedure that Dr. Lin and we did last week, which we combined the biomechanical benefit of titanium instrumentation, but also some of the benefits of carbon fiber in terms of imaging and post-op radiation planning. So doing a kind of a hybrid approach to spine instrumentation. Some of the limitation of newer instrumentation is the high cost and the limited the fact that it's not quite customized. We are able to customize the instrumentation and the rodding, and also the uncertain long-term structural integrity of carbon fiber instruments. Thank you.
I know we're running short on time. That was a great case. Thank you. Any follow-up on that long-term, or is that just a recent case?
This young lady, we followed her. It's been 3 years, and unfortunately, she developed a lung metastasis that required her to get a wet resection, but she remains tumor-free in the surgical bed and neurologically intact. She actually got married about a year after her surgery.
Great. Thank you.
Great case, great audience today. Really appreciate our partnership and great collegiality with our OHSU colleagues. Super difficult topic, so much to talk about, anterior first, posterior first, posterior only, adjuvant therapies, etc. But I think this was a really cool discussion of the various problems as we face. So thank you, OHSU. Thank you, Dr. Lee, for spearheading this, and your wonderful team. Great statement in favor of multi-specialty care. All right.
Thank you so much.
Thank you,
Good
everybody.
night, everybody.
Thank
Take
you.
care.
Nice.
Bye-bye.